So it's great to be here. And as he said, I'm a practicing dermatologist who, in an unusual way, does really 100% of my part-time faculty position doing PDT. So this is from a clinical perspective, but there's some research involved as well. I do some consulting for Sun Pharma and Biofrontera, the two major players in U.S. journalogic PDT. And so what I'll tell you today is just a little bit about PDT overall mechanisms. What's the difference between blue and red light in PDT? What it's used for, and then some newer ideas about reducing pain and improving the efficacy of PDT. And finally, a little bit about new ideas that it could be an immune modulator. And as I click, nothing happens. Forward, click mouse button on left to advance. Right, there we go. So PDT has you can define it, I think, in a most parsimonious way by this phrase here. So it's really the use of a photosensitizing drug plus visible light. And you need oxygen as well to generate cytotoxic molecular oxygen and other species that eventually kill the target cell. And so I'd like to represent it as this pyramid where you have the light, the drug, oxygen, but you also need a fourth element, which is the target cell needs to respond properly, either by direct cell death or stimulating an immune response. And then the other basic element of dermatologic PDT is that there are really these two flavors. And so it's really a combination treatment of drug and light. And so when you go to the FDA, you have twice the problems that you would with just a device alone or a drug alone. So in the States, really these are the two FDA-approved formats for PDT. So both of them involve aminolevulinic acid, or ALA. So 20% ALA in an alcohol solution on the left combined with blue light, or 10% ALA in a nano emulsion formulation with red light. And so this is what we're going to confine the talk today about, the use of these FDA-approved modalities. And then everything really centers on this pathway here, this little slide. Is the target for the light is the molecule on the right. It's a porphyrin, a tetraperol molecule, and it's very good at absorbing photons and then producing chemistry at which when it breaks down, it activates oxygen and kills membranes. And so you could use this, it's really heme from the blood. But in dermatology, we use a much more clever trick, which is to have the cancer cell itself produce the heme. And the pathway shown here, we're going to bring it back again, but the basic idea is you give aminolevulinic acid, or ALA, as a prodrug, and it bypasses the initial step in the cell in the synthesis of heme. And because of that, the cell can just produce so much porphyrin that it's like a horse going to water. You know, it just doesn't know when to stop drinking. And the cell gets loaded up with the pink molecule here, the PP9, and that's your main target. So we'll get back a little bit later to that, but then the other major question is, why red light, why blue light, and when do you use them? And there's been this sort of dogma about the depth of penetration of these two wavelengths, that blue light goes shallow, red light goes very deep. And in essence, that's true from a physical sense, but then in a practical way, turns out it may not be that important or that limiting. So what I'm showing here is a study we did 6 years ago comparing red light PDT or blue light for multiple basal cell carcinoma in patients with Gorlin syndrome that have hundreds of tumors. And in this study, we had 3 patients. In total, they had 141 BCCs on their body. That allowed us to, in each patient, treat half of those with blue light ALA and the other half with red light and ALA. The details are in the publication, but there was long 4-hour incubation followed by 30 minutes of blue light or 10 minutes of red light. And the point is that they had the same response, 90%, over 90% clearance rate after 3 treatments. And it was the same between blue and red light, which was a little surprising to us. But a possible reason is that the blue light, even though it has 10-fold less depth of penetration, absorbs the light 10 times better. So these two things may cancel out. At least they seem to do in this setting. So just a brief skim over what diagnoses are currently used or treated with PDT in the US. And it's a short list, I have to say, a little unfortunately, where everyone's working on it, but right now, the only diagnoses that are FDA approved are actinic keratoses, which of course are pre-squamous cell carcinoma, and then acne, but that is without the drug, just blue light, with the idea that the microorganisms in the oil glands themselves make PP9 photosensitizers, so they have their own photosensitizer. But off-label, we use it a lot for SCC in situ, or Bowen's disease, which is more advanced, AK on its way to squamous cell carcinoma, porokeratosis, which is another sun-related induced precancerous condition, and then extramammary Paget's disease, which is pretty rare, but I just put it here as an illustration of where PDT can be very good as a palliative measure or control measure, even if it's not particularly curative. So here's an example of one of our patients who has extramammary Paget's, which is an intraepithelial tumor which around genital mucous membrane areas. And in this case, to save the patient from more disfiguring surgery, we've been using PDT to keep it in check, and it's been quite helpful. So kind of the wider picture of the uses of PDT, for that you have to go overseas or into the research setting. So for basal cell carcinoma, this is actually approved in Europe, and there's been a lot of work on use of both blue light, red light, PDT for basal cell in Europe. What I showed you earlier was a research study here in my group. But for acne, for using the Levulan PDT combination, a lot of nice work ongoing, and Dr. Sakamoto, who's up here, has done a lot of work on that, and I'd be very interested to see where the gold nanoparticle and light activation is going. And then a lot of work in China, and actually I was glad to see that Dr. Zuli Wang from the Shanghai Skin Center is here at this meeting giving some talks, her group. And they've done a lot of work on not only cystic acne, but warts, even vascular hemangiomas in the larger research community in China. So there's a lot of, they have fewer restrictions on doing these clinical trials over there. There's interesting uses in parasites, bacterial leishmaniasis. And the last two things on this slide, cervical cancer and oral cancer, just illustrate that mucous membranes, even though they're not the skin per se, are a nice extension, and they respond very well to PDT. And I highlight a study by Tayyaba Hassan's group with her brother in India, where they treated oral cancer in patients with blue light, and it was really quite promising. So what I want to really do with the majority of this talk, though, is to talk about some new techniques for old diagnoses, mainly actinic keratoses, and how we've been working to try to reduce pain and improve the efficacy of the treatments. And these two goals are kind of tied together, because you can't improve efficacy if the patients won't even come for the treatment. And what I'm referring to here is that with conventional PDT, inflammation, the pain, are a big problem. Here's a patient who we did in the traditional way of apply ALA, leave it for 2 hours, and then during the time that the blue light is on, it's extremely painful, and we have to cool his skin with ice water, and then afterwards you get this pretty terrific inflammatory response. And many patients won't come back. And so you can't really improve the use of PDT if you get a bad reputation with patients and everyone they tell. So we got a clue on how to maybe address this from a study in Copenhagen. Now it's like, what, 16 years ago, with daylight PDT. And they actually figured out you could apply your photosensitizer or ALA to the skin and then ask the patient to just go out in the hospital garden in the sun. And they showed that there was efficacy with this short, maybe 15, 30-minute incubation, and then 2 hours in the sunlight. And that's just the opposite of conventional PDT, where we have long ALA exposures. So this was, and the key point here is that there was no pain. It was completely comfortable. But there are two problems with bringing this to the States. First of all, it's hard to control the light dose between Miami and Bangor, Maine. And the other thing is the sunlight actually, of course, has ultraviolet wavelengths in it. And this is carcinogenic. And kind of ironically, the Copenhagen group later suggested what they do here is they build a greenhouse out in the garden, which the glass will block the ultraviolet while they're getting their PDT. So it's kind of cute, but not very practical. So we thought, what if we can use our existing devices, our blue light, artificially, and simulate the daylight PDT paradigm? And this is what we're doing now. You apply your ALA, wait a very brief time. In the study that's quoted here, we did 15-minute pre-incubation. Now, actually, we've just been starting right away, 0 incubation. And then you illuminate for twice as long as we used to do. So it's now 30 minutes. And we get equivalent efficacy. I have to admit there was some skepticism when this first came out that could this really be working? So we've been doing this for the last several years, and we just published a real-world validation with 100 of our patients, where we asked them to go home, take pictures of themselves with their iPhone 2 hours or 2 days afterwards, and then send them to us. And then they also recorded their side effects, the itching, inflammation, and we compiled this. And what we found is there really 99% of patients a significant inflammatory response with erythema, which we could quantify in with a semi-quantitative score shown here. And when you do that and do it by facial region, so on the forehead, temples, cheeks, nose, and you find that correlates, the amount of erythema response correlates with the number of target lesions that were counted in that area. So there's a nice a dose-response relationship, which argues that this is really a valid technique and interpretation. So, but there are other ways. So now I want to focus on how can you improve the efficacy and lesion clearance. Of course, for years, the obvious thing has been to improve penetration of the drug. And there's a lot of interest in microneedling, and you can buy these packs off of Amazon or microneedle roller format. So it's amazing how many publications people can do on things like this. And then the other extreme is you can use your lasers, which at this meeting, this is kind of ironic to say that this could be, but people have published nice work to show that you can create holes in the skin and the lesions before you apply your photosensitizing drug. Works great, but the financial outlay seems to, doesn't quite match the outcome. So You can go the other direction. I love this from the Zuli Wang's group in Shanghai. They do what's called plum blossom needles, and this is from a paper that she did to explain that. It's basically a little hammer with, I think there's 6 or 7 small needles at the end, which is shaped like a plum blossom. That's where the name comes. And you bang on the patient's face, on the lesions, to create the holes for penetration. It apparently works pretty well. So we've taken a little more Lowe's or Home Depot approach here, and we've shown that you can use sandpaper for this curettage, this preparation of the lesions, to abrade the skin. And we just borrowed from our cardiology colleagues who use this EKG tape, which is very inexpensive. And they use that to prepare the skin. We use it to prepare the AK lesions, and you can improve by almost 50% your lesion clearance, especially useful on the scalp, which is quite recalcitrant otherwise. Now, the other little more elegant approach, I think, for improving efficacy is to manipulate the metabolism. So I'm bringing back that original diagram here to show you that the steps in the pathway, there are actually 8 steps from the precursor in the mitochondria to the heme at the end. The goal is to have more of the pink molecule, the PP9. But if you could modulate any of the steps in this pathway, you'd be ahead. So for the metabolic handling, this is a potential things people have tried. You can prevent the PP9 effluxing out of the cell. So Dr. Chen in Philadelphia has shown you can block a transporter that does this. You can enhance synthesis of PP9 by increasing the skin temperature. And Andrea Willey and Rox Anderson and Fernanda have published about wrapping the skin in a warming blanket, raising the skin temperature to increase enzyme activity. You can block the last step, which is ferrochelatase, where you place an iron atom into the budding or nascent tetrapyrrole. And if you block that last step, you accumulate PP9 behind it. And so using iron chelators is an approach. And then the 2 approaches that we've done and published on somewhat recently are pretty practical, I think. One is to use our tried and true derm drug, fluorouracil, which is shown to improve and increase the levels of some of those enzymes in the pathway I showed. And you apply the cream once a day, not twice, just once for 6 days prior to the PDT. And you can get significant improvement, almost doubling actually, of lesion clearance. And then the other published work is vitamin D, which on a molecular basis does a similar thing. And it's quite practical. Here you can take pills. This dose of 10,000 units is 5 times higher than the recommended daily dose, but very safe. Do that every day for 6 days just before coming in for treatment. Now, I wanted to describe a new study that we've done, going back to the idea of pain reduction. And we've been working with Biofrontera, which is the company that makes the nano ALA formulation, to see if we could modify their protocol. With the FDA-approved protocol is a long 3-hour incubation, very painful. And trying to apply the principles from our blue light protocol. And we have the 3 groups in our study with 30 patients. This is interim results, so it's not finished, but I thought I'd like to show you. So these are the 3 groups. And group A is very short, 10 minutes incubation with red light. Then the second one is 20, and the group C is 1 hour. All of these are still shorter than the approved one, but we wanted to see what was happening. So you do day 0 a treatment. They come back for photos. And then at 8 weeks, they get a second PDT treatment with the same protocol. And then 3 to 6 months is your final follow-up. So here you can see just the appearance of the patients, the erythema. So in the long incubation, group C, you get a lot of inflammation 3 days out, as sort of expected. But in group B, you also get limited but targeted inflammation of the lesions. And then, but the nice thing, interesting, is that for the short incubation group, you still get inflammation. So this was very interesting and in line with what we'd seen before. In terms of pain, we're definitely seeing very low pain levels in group A and B. This is on a 0 to 10 pain scale. Group C can be quite painful. Actually, one patient dropped out, but for the most part, it's still within the tolerable range. And then what I'm most excited about are these interim lesion clearance results that show that in all three groups you get a very similar pattern, at least 50% clearance after just one treatment. And after the second, that bumps it up to 70%, give or take. And the short incubation groups are very similar. And this slide shows that compared to our shortest incubation, it's equivalent to what we were seeing with our 5FU study back in 2018, with at the first time point, 3 months after treatment, about 50% clearance. And with fluorouracil, you could improve that to a little over 70%. So very interesting new data. So just in the last couple minutes, I wanted to point out some of the new directions of PDT as an immunotherapy, that this concept that it may actually not just be all about immediate cell death at the time of blasting the lesions, but in fact might do something else, which is to engage the immune system. And so this is work that's been done in the laboratory over the last decade, many labs around the country, but showing that PDT induces reactive oxygen species, cell death, but then it also induces damage-associated molecular patterns, or DAMPs, and this will then stimulate the recruitment of neutrophils and macrophages, which is the first early phase of the immune system, and dendritic cells. And then through the work of cytokines and how antigens that are processed by these macrophage-like cells, they're taken up into lymphocytes, and you get a more long-term immune response. So we've been playing with this in mouse models, and I just want to show you this work that we've done in the last few years using a mouse model of actinic keratosis. So these are mice that received 20 weeks of twice a week ultraviolet UVB irradiation in the laboratory, and at that point they grow actinic keratoses, and we can treat them with PDT either alone, or we also tried our combination of vitamin D for 3 days in the mouse, followed by the PDT treatment, and then we would harvest the lesions in a time course to see what immune reactions are happening in the tissue. And something actually important is happening. You see recruitment of neutrophils and also of dendritic cells, which are the innate immune cells in the system. And you see that open circles are PDT alone, and the closed circles on this graph are in combination with vitamin D, and you see that augments the increase in the cells recruited into the tumor. And then importantly, the next step is the adaptive immune system, or T cells. And I'm showing here we've stained for cytotoxic T cells. And this, over time, also is recruited, but later than the innate immune cells. So it all makes sense. They're coming in, being programmed to attack and reduce the pre-cancer actinic lesion. And again, vitamin D augments that. And then finally here, what's really interesting is that so there's always the good and the bad. So I showed here that the cytotoxic cells are good. You expect that kills the lesion. But you also can get a response where the tumor is able to fight off the immune attack. And this is the immune checkpoint receptors ideas, like PD-1, which everybody is talking about, and pembrolizumab and other drugs, similipimab. And when these are expressed, you'd expect that to be deleterious, not beneficial. But when and in fact that happens, you see with the open circles, PD-1 is increased, which could be bad, but if you added vitamin D, it seems to reverse that process. So we're pursuing this as a potential avenue where our combination treatments can affect the immunity. of the tumor. So my time is up, so I'm going to summarize. I've shown you that PDT is really best for cancerous neoplastic condition, and we're working on improving the PDT, and that work centers on really improving efficacy after reducing pain. And then pain can be reduced using short-term protocols. It looks to be more universal with red and blue. And the immune system is a new frontier in PDT research. So with that, I will close and acknowledge the group at Cleveland Clinic, both our clinical and in the lab. Dr. Anand has done a lot of all the mouse work that I've shown, and our collaborators at Natalie Zatuni at Phoenix, and most importantly, the Tayaba Hassan and her program project, the PO1 grant, which has really kept us going for quite a while, and continuing, and the funding sources. Thank you very much.